Good afternoon. Ben Paulos here. I want to congratulate everyone on a great meeting so far. I think we're really looking forward to this session. We've had a couple of sessions with the American Hernia Society Quality Collaborative. I think this is a really exciting and unique session of that because this is really the first time that all the hard work that's been placed into collecting data and engaging our surgeons, engaging our patients, is now coming to fruition, where we're going to look at some real-world information on things that you can take back as surgeons back home on Monday and actually make practice changes. Even if you don't participate in the Quality Collaborative, you can take this information home as a surgeon to help you and help your patients. So I just wanted to, as a matter of housekeeping, put up a disclosure slide of where the AHSQC gets its funds. I think this is really important to interpret the results, which certainly have pluses, certainly have minuses. I hope this leads to a healthy discussion. Our funding comes from the American Hernia Society. Part of the American Hernia Society Quality Collaborative Foundation is funded by LifeCell, Bard Dayball, Incitra Medical, Covidien, Medtronic, Mackay, and Intuitive Surgical. With that, if we could go ahead and cue up the next speaker slides, please. So I'd like to introduce our first speaker. I think this is a really special opportunity, not only for the AHSQC, but also for the American Hernia Society, in having a member of our United States Food and Drug Administration, Dr. George Jabali. Dr. Jabali is a medical officer for the United States Food and Drug Administration in the General Surgery Device Branch. George got to know him over the past couple of years. He is a general surgeon, and he's also obviously a member of the FDA. The FDA, incidentally, is a member of our AHSQC Executive Council, and it's part of this idea of a collaborative effort on ultimately trying to improve care for our patients. And Dr. Jabali is going to speak to us on leveraging registries to improve patient care for regulatory use.
I'd like to thank Dr. Rosa and Polos and the American Hernia Society Quality Collaborative Executive Committee and members and this audience for the opportunity to represent the FDA at the 17th Annual Hernia Repair Meeting. I've been an FDA medical officer for a couple of years. I'm in the Center for Devices and Radiologic Health. Before that, I was a general laparoscopic surgeon for 30 years, and I relinquished my scalpel for 3 computer screens. But honestly, being a medical officer at the agency has been a fascinating second career for me, and I'm humbled and privileged to work with really brilliant scientists, engineers, and medical officers. I have no disclosures. You know, our goal at the FDA is to ensure safety of medical devices without stifling innovation. It's a difficult goal, but we try very hard to do that. On May 28, 1976, the U.S. government passed the Medical Device Amendment Act to the Food, Drug, and Cosmetics Act in response to safety issues with medical devices, and thus establishing CDRH. We approve and clear thousands of medical devices each year, and we're becoming increasingly interactive with industry to help streamline the process of bringing the best medical devices to our patients here in the U.S. We use valid scientific evidence in the least burdensome way to provide reasonable assurance of safety and effectiveness. We stratify devices based on risk, Class 1 being the lowest risk device and Class 3 being the highest risk device. With Class 3 devices, we require pre-market approval in clinical studies. Class 2 devices, however, the medium risk devices, such as surgical mesh, can undergo what we call pre-market notification and clearance through the 510(k) regulation of the Medical Device Amendment. Here, industry simply has to demonstrate substantial equivalence to a pre-existing, or what we call a predicate mesh. If the new mesh has the same indications for use, has similar technology, or technological differences that don't raise new questions of safety and effectiveness, then they can be cleared for market with what we call special controls. Frequently, these meshes are cleared without clinical studies, only about 10 to 15% have clinical studies. It's our regulation, it's the law, and in the vast majority of cases, this seems to work. Since 1976, we've cleared over 400 surgical meshes, 200 are still on market, and since 1998, at least 15 collagen meshes have been cleared. The problem is the engineering and the manufacturing processes have become so complex that for these new meshes that you have to wonder if they're really equivalent to the older product, although on paper they certainly seem to be. For this reason, the FDA believes that following these meshes post-market is critical, and we're looking to the registry to help facilitate that effort. Currently, the agency's post-market surveillance consists of MDRs, medical device reports. This is a passive system. Anyone can generate an MDR, and unfortunately, they're frequently incomplete, incomprehensible, duplicated, filled with errors, and when we get a legitimate adverse event reported, we feel it's underreported. And to add insult to injury, we don't know what the true frequency of device use in the marketplace is. We don't have the denominator. It could be 1 in 100 meshes used this adverse event, or 1 in 100,000. So it's a problem. We have a more active reporting system called MedSun, or Medical Device Safety Network. It was launched in 2002. Only 300 hospitals nationwide participate in this process, but with this active reporting system, if you're in the OR as a surgeon and you institute an incident report, that report will go down to your hospital risk management, and those folks will determine if it's a device-related problem. They have immediate access to an FDA analyst who has all the device information at their fingertips and can see if others are reporting the same safety signal. And in addition, they can reach out to our external partners, MD EpiNet, or Medical Device Epidemiology Network, which is a volunteer organization of experts in epidemiology, statistics, clinicians, as well as industry representatives. They can do further look-see to see if this is a true problem. They can do more research, they can gather more data, and if it is a significant problem, the FDA can then institute additional post-market studies. We don't think that's enough, and one of the agency's strategic priorities has been to strike the right balance between pre- and post-market data collection. We're pretty good at gathering data pre-market, but once the product goes out post-market, we don't hear from it unless there's something really bad happening. And we feel like we need to hear from, know how these devices are performing in the marketplace. So in 2012, the FDA issued a mandate to develop steps to quickly identify poorly performing devices and generate real-world evidence of the benefit of new technologies and support future device development. Well, it just so happens registries have many of the same goals. And so currently, the FDA is affiliated or associated in some way with 20 registries nationwide. And in addition, we are currently affiliated with the American Hernia Society ACHQC registry, and we have over 60 FDA-initiated post-approval studies using registry infrastructure, looking at devices more carefully. And so while we think registries are great and we highly encourage the use of registries, we can't mandate the use of registries and we can't run registries, and that's maybe a problem. We think they're great learning systems to provide actionable knowledge, allowing stakeholders to make informed decisions, and stakeholders such as patients and surgeons and professional societies, government organizations such as the FDA and Centers for Medicare, Medicaid, CMS, hospitals, payers, and the medical device industry. I think all stakeholders have something to gain from registries. And while clinical studies are important in device evaluation, they're conducted in specialized centers. And patients that meet specific inclusion-exclusion criteria and have an equal chance of receiving a specific treatment, carried out over usually a short period of time. The problem is most patients don't fit in those very specific criteria. And the other, perhaps bigger problem is that the total product life cycle of most medical devices lasts much longer than the duration of clinical studies. That is, say, for example, a hip implant will last 15, 20 years. But studies evaluating hip implants are at best 2 years duration. So what happens in the other 13 years when that implant's in the patient? We don't know. Surgical mesh studies, if done, when done, usually last less than 3 years. So what's happening to the implanted meshes at 10 to 20 years? I think your patients are going to want to know this before you put mesh in them. Surgeons want to know if a particular mesh repair is going to decrease the recurrence of hernias or simply delay recurrences. And clinical studies may not be able to provide this data. Registries, on the other hand, provide information on how the device functions in a wider population of patients, in more diverse clinical environments involving clinicians with different skill sets, and hopefully over a longer period of time. And I think that's important. They're critical for continuing quality improvement, and certainly can be very helpful in detecting that early device safety signal. Published studies take many years. Registries provide immediate feedback, real-world, real-time data. And so we think this is crucial in our post-market surveillance. Furthermore, registry data can be used as contemporary controls for studies of other devices in the same class. It can be leveraged to inform device indications for use and labeling. Registry infrastructure can be used to enroll large numbers of patients and investigators for pivotal trials or randomized controlled trials. You know, I was told that for a 100-patient study followed over 1 year, it costs industry about $20 million, which is a significant sum, especially for smaller companies. If you can make any dent in that cost, I think it would be worthwhile. In September 2013, the FDA mandated that unique device identifiers be placed in product labels of all medical devices sold. With the UDI, we'll be able to track devices and the patients in whom they're implanted through what we call the Sentinel surveillance system, which is a really complex software meshed with a very supercomputer that will be able to interrogate multiple databases and follow devices longitudinally over time. We hope to see that happen. It'll also help develop hybrid databases with administrative databases, CMS, insurance claims, and possibly electronic medical records. It'll facilitate the global linking of registries. This is already being done with some of our orthopedic registries, so the American Orthopedic Registry is hopefully going to link with the European registry, and hopefully that can in the future be facilitated for the hernia registry. It decreases the burden of data collection, eliminating errors and duplications. I think probably a very important benefit of this system is that finally we're going to be able to accurately determine device frequency of use. So we're going to have a denominator for our adverse events. We'll know if it's 1 in 100 adverse events or 1 in 100,000. I think that's important. So the take-home message is pre-market studies, including clinical studies, don't always give you the whole picture of safety and effectiveness for medical devices, especially with regards to the total product life cycle. And registries are uniquely positioned to allow stakeholders to gain actionable, real-world, real-time, longitudinal knowledge on medical devices, and I think it requires teamwork and collaboration with a spirit of learning and problem solving. And so the FDA is pleased to be ex officio members of the Executive Committee of the America's Hernia Society, QC. Thank you.
Thanks, George, very much. I just want to kind of recognize, I think how important it is, particularly when we run this collaborative, that we have all the stakeholders at the table. And I think it's a rare and exciting time that we actually have the FDA that comes here as part of our collaborative and really informs us on what their role is so we all understand what each other is doing. So as we move forward now in the program, I want to be crystal clear with everybody in the room We aim to change your practice. What you learn right here, right now, at this part of the session from the AHSQC, in my opinion, should be what you go home to do. Continue what you're doing or change your practice. So I want you to look carefully at this. There's a lot of time and effort that's gone through this data. So these next couple talks are really the first operational time of the AHSQC and all the data that many of you have put in. So without further ado, it's a pleasure for me to introduce my current fellow and future partner, Dr. David Capata, who is now has a task of changing your practice.
I do that and follow the FDA, and then I got to be your partner. This is good. All right. So, first off, thank you for the opportunity to present this data. I'm going to focus on bowel preps and elective ventral hernia repair. I have no disclosures. Does anybody out there know who this is? This is Joseph Lister, the father of asepsis, who in 1865 sprayed carbonic acid on surgical sites and surgical instruments in an effort to reduce surgical infectious complications. Now here we are about 150 years later. Instead of using carbonic acid, we're now using a quality collaborative in an effort to reduce surgical site infections. Now along that 150-year spectrum, though, there's been other approaches towards trying to reduce surgical site infections, including the concept of an aseptic anastomosis, which in the early or late 19th century, early 20th century, there was a lot of work into trying to create an anastomosis while reducing or even eliminating contamination. And the importance of this was highlighted by Halstead in 1912, who said that soiling unquestionably contributes to the mortality attending the circular sutures, particularly of the large bowel. But how important this factor is cannot be fully determined until a child has been completely eliminated. And there's multiple approaches you can take to this. Some are technical. Halstead actually performed bowel anastomosis over balloons in an attempt to try and reduce contamination. But the concept of colonic decontamination through fecal debulking and bacterial eradication came about. Some of the earlier efforts of this were through elemental diets and laxatives, but are now what we consider mechanical bowel preps and antibiotic bowel preps. So some of the earliest data for this was in the 1970s, and it was actually by some hernia surgeons. Dr. Nias and Dr. Condon, who did work on this in Chicago, actually looked at prep bowel and non-prep bowel using the mechanical bowel prep and showed that there was no change in the bacterial load within the colon or the stool or the small intestine with mechanical bowel prep. But if you added antibiotics to that, you could actually nearly complete bacterial eradication of the colon. Interestingly, you could also induce C. diff in 1972 with this approach. So, as time went on, in the 1980s, 1990s, the trauma literature began to sort of reject the idea that you needed a bowel prep based on the fact that you could perform colonic injury repair in the face of contamination without any issues. And in 1992, the first randomized controlled trial for bowel preps was performed, and it showed no benefit for any bowel prep. And in 2011, the Cochrane review of 14 randomized controlled trials and nearly 5,000 patients showed no statistically significant evidence that the patients would benefit from mechanical bowel prep. In that same year, 2011, the survey of colorectal surgeons, despite all this evidence, showed that over 40% of them were still using bowel preps. Well, that's the colon. We're here for hernias. So what about hernia surgery? Is anybody actually using a bowel prep? And if they are, is it actually helpful? All those are the questions we asked. We had two aims of this study. The first was to determine the prevalence of the bowel prep during elective ventral hernia repair. The second was to evaluate the impact of bowel prep on surgical site occurrences. We utilized the AHSQC database. We searched populations of elective ventral hernia repair, looked at clean, contaminated cases, and we compared bowel preps versus no bowel preps. We kind of separated this into two parts. The first was the clean cases, where we did a matched analysis of 3 non-prep bowels to every 1 bowel prep. And patients were matched based on ASA class, hernia width, hernia grade, history of abdominal wall infection, and the open or laparoscopic approach. And then for our class 2 and 3 cases, we did a multivariate regression analysis. The outcomes we evaluated were at 30 days, and we looked at surgical site infections, surgical site occurrences, which include surgical site infections plus fistulas, wound cellulitis, seromas, or other wound events. And then we wanted to know if there was any requirement for a procedural intervention for any of these surgical site occurrences, such as wound opening, percutaneous drainage, or even an operation. So the first question is anybody actually using a bowel prep? And if you look at the AHSQC database, and this is from a week ago, 6,607 patients, 767 patients had a bowel prep for an elective ventral hernia repair. That works out to 11.6%, or 1 in every 9 patients is receiving a bowel prep for an elective ventral hernia repair. So we look at the clean cases now. Remember, this is a matched analysis of 3 non-bowel preps for every 1 bowel prep. It's totaled out to 1,227 patients. 313 patients had a bowel prep. 98% of those were mechanical only. 1% were combined oral antibiotic and mechanical, and 1% was antibiotic only. And this was matched. We had good rates or equal rates of diabetes, hernia grade, laparoscopic approaches, history of abdominal wall infection between our 2 groups. And the overall incidence of surgical site infection for those who had a bowel prep was 4%. For surgical site occurrence, it was 22%. And for those who did not have a bowel prep, the surgical site infection was 2%, and surgical site occurrence was 14%. And if you do the statistics on this, this is a significant difference where patients who had a bowel prep had significantly more surgical site infections and surgical site occurrences. Fortunately, patients who did have a surgical site occurrence did not have higher rates of procedural intervention for them. So in this group, what actually did predict surgical site occurrences? Well, those 4 things: BMI, bowel prep, laparoscopic approach, and history of infection. So bowel prep had a 1.76 times higher rate or odds ratio of having a surgical site occurrence if you had a bowel prep. Did anything actually predict procedural intervention? Well, if you had diabetes, or if you had a drain or the lack thereof a drain, that will be discussed a little bit later. But for bowel prep, the odds of requiring intervention were 1.64 times higher, but this was not statistically significant. So for our potentially contaminated cases, we had 645 patients, 152 patients who had bowel prep. 3/4 of those were mechanical bowel prep, 1/4 was a combined oral antibiotic and mechanical bowel prep, and 2% of patients had antibiotics only. Even though this wasn't a matched study, we did have comparable groups, equal rates of diabetes, ASA3 class, smoking, and BMI. And when we did our multiple regression analysis, it showed that there was no association between bowel prep and wound events, whether it be surgical site infection, surgical site occurrence, or surgical site occurrence requiring a procedural intervention. And we controlled for multiple variables in this study. So in conclusion, bowel prep does not appear to reduce surgical site infections and may actually increase surgical site infections and surgical site occurrences in elective ventral hernia repairs. As a result, bowel prep should probably be omitted from preoperative preparation of elective ventral hernia repairs. So thank you for your time.
We're going to hold off questions till the end if we have time for a panel session, but after each one of these, I just want to give you guys kind of just remember that collaborative learning cycle. Everybody who is a member of the Quality Collaborative or not, in my opinion, it's time to stop using bowel preps. And then we will study the effect of that change over time as well and be able to see what happened from this meeting on. And that's what we're here for, and that's the take-home point. Definitively, in my opinion, bowel preps need to stop. It's my absolute pleasure to invite Guy Ballard up here because one of my favorite things to do is be impassioned about something and a couple years later say I was wrong. So this is one of those special moments.
He actually called me crazy.
That's right. I call him lazy. I call him crazy. But this is one of those special moments in my life that are coming all too often. That the data actually proves that my bias was actually incorrect. So it's an absolute pleasure to give Guy the chance to gloat with actually some of my own data.
Not gonna gloat. No disclosures. The onlade's been around. I'm guilty for putting Chevrolet aside. Let me go back to the title that I selected. See if I can go back. Once I can go back. Yeah, my title, I picked this title. Ben called me up and said, hey, would you present the data? And I said, well, you can present it. And he said, no, I want you to. I put Chevrolet in there because I'm as guilty as all of us for poo-pooing the onlade. Many years ago at this meeting, I said the Reeves Stopa retrorectus repair was the standard of care. So now everybody ran with it. I taught Todd Hedford how to do it. He taught Mike. Everybody thought Reeves was the only way to fix a hernia. I was as guilty as everyone. And so I feel bad about not giving Chevrolet his due credit. But the onlade's been around. This is a nice study from 2006 looking at a Reeves retrorectus repair and an onlade repair in pretty good sized hernias, 10 centimeters or less. And again, you can see the onlay was better as far as recovery, return to work, and the recurrences were pretty similar. Same thing here. This is a true Chevrolet repair. This was published in Hernia in 2008. You can see seromas, which you'll get, and all the other issues. 2 recurrences. Onlay is safe, easy to perform, reliable. Dr. Kingsnorth, European Hernia Society president, big believer in the onlay repair. Again, good results with the onlay approach. This is a study from Denmark. 56 patients with 100% follow-up. Mean follow-up was 3 years, so pretty good. Complication rate, no mesh loss. Recurrence rate was 13%. Conclusion was low recurrence rate, low complication rate with the onlay technique. So we all said Reeves is the only way to fix a hernia. There's a picture of Dr. Reeves in '92 and Dr. Reeves in 2009. May he rest in peace. Wonderful man. So the guy in the middle there, George Watts, went to France. Of course, the Europeans in the audience know they've been ahead of us a long time in hernia repair. But Dr. Watts went over and learned the retrorectus repair from Dr. Reeves. And in 1982, I was a resident. A lot of you were not born then. But in 1982, I was a resident, and my mentor at the VA invited Dr. Watts down to Memphis, and in the operating room, he taught me the Reeves retrorectus repair as a resident. So it was the repair I did. That's what I learned. It was the standard. When we developed our laparoscopic approach, we based it on the Reeves repair, since that's what we learned is open. We actually took Dr. Watts's pictures of the Reeves repair and showed them as we developed our laparoscopic suture-based repair, and that's how the Reeves repair became popular in the United States, was due to the laparoscopic explosion in the 80s. So everyone, the Reeves is the way to go. Dr. Reeves came up with the repair because he wanted the mesh behind the hole but out of the belly, and so that's why he sewed the posterior rectus together, and that's why he came up with the repair. Flemont was a student of Reeves, and you can see the results are good. We know it's a good repair. 6.2% recurrence, 258 cases, excellent long-term results. We know that. It's not perfect though. Alfie and Will just presented and published in JACS their experience with the Reeves repair. And you can see that wound events is 37%, SSIs is 19%, recurrence rate was 17%, so it's not a perfect repair. No repair is perfect. We also know that it doesn't matter where you put the mesh. You can put it onlay, underlay, sublay. As this study showed, this was with hernias that were either large or giant hernias. They did 8 IPOMs, 8 sublays, 8 onlays, and then they measured the strength of the abdominal wall of the Biodex machine, and the strength was identical. It didn't matter where you put the mesh. So Chevrolet, this was his technique. He thought the midline closure was very, very important. They did studies that showing if you folded the anterior fascia over, sewed it together, it created a very strong closure. Then he would suture his mesh on. He used the adhesive for the midline closure, and then later expanded it. Him and Rath went to the lab and they measured the strength of the posterior rectus sheath, and they showed that the posterior rectus sheath is a pretty weak structure. You can see its resistance there is quite low. You put a piece of mesh there, the first thing that sustains the intra-abdominal pressure is the posterior sheath. You've got the mesh there, so the posterior sheath rips, and then Chevrolet was concerned that the bowel would be exposed to the viscera. So he felt that the onlay position of the mesh allows its tension to be determined at the moment of fixation, which it does. The biologic glue has an immediate effect on fixation. For those of you who've never done this, you'll appreciate this when you do it. If the mesh becomes infected, you can always salvage it. It's rare that you'll lose a piece of mesh, and it's rare that it contacts the viscera. Here's Chevrolet's results. Pretty good follow-up, 1 to 20 years with 93% follow-up. None of us had 93% follow-up. You can see his recurrence rate was less than Dr. Reeves' recurrence rate. So 2003, Kakuta, Kess, and Schwab, 2 Europeans and a European in America, looked at adhesives and showed that in inguinal hernia, the mesh moves. And you can suture it or you can glue it, and it will prevent that migration and that movement. And they showed that with adhesives, the strength across the abdominal wall is better, and the resistance to movement is better. That's a repair of mine, a TEP repair. So we went to adhesive fixation in 2003. So Nate Stoics came to us. He was our resident. He went up and spent a year with Brent Matthews, came back. We got with our engineers. We set up an adhesives lab. We looked at adhesives. The nice thing about adhesives is that the fixation is a function of the surface area, whereas with mechanical fixation, it's a function of the strength of the tissues and the strength of the construct that's fixing it. And with adhesives, you've got, like I said, you've got better load sharing with adhesives. You get less contraction of your mesh, so I became an adhesive fan. One day, about 2009, 2010, I had a patient, and Mike said I'm old and tired, and I think it was, I was old and tired, and I said, well, I don't know what I'm going to do. I'm going to close this, and I'm just going to put a piece of mesh on and glue it in place on the top. Remembering Chevrolet's word. And it worked, so we looked at our first 50 patients, and Nate posed this, an American surgeon, and then last year at SAGES, we presented 97 patients, and it looked pretty good. Is the audio up on this next coming up video? This is a 7-time loser from Alabama. You can see he had 2 large defects there. The one on the left was the one that was hanging down off of him. So we did some releases, got him closed. That's a piece of medium weight mesh, 30 by 30, costs $150. Skin staples and then adhesive.
How many days since we did your surgery now?
Oh, well, it was on the 24th, so it was last Friday. Friday was a week.
Okay. Took one drain out today. Taking any pain pills?
No.
No pain pills? When's the last time you
I'm a tough old man.
When did you take the last pain pill?
I don't know. I ain't took but 5 since I left here at the hospital.
Okay.
I'm serious, I ain't. I drove all the way back over here Saturday. to Bass Pro Shop.
Did you really?
You like that? Welcome to Memphis.
24th?
24th of
April.
April, this is May, what, 12?
Yep.
How you feeling?
Good.
Cough for me. All right, cough again. All right, how you feeling?
Good.
Traveling, getting around, doing things?
Yeah, driving myself over here, driving anywhere I want to go, doing what I want to do.
All right, come on.
So anyway, I won't belabor that. So Ben, everyone said I was crazy, and I thought maybe I was, because the onlay has not gotten such a bad name. And again, the key thing here is technique, it's patient selection. It's not for everybody, and you learn when you screw up and do it on the wrong patient. You realize who should do it, and who should get it, and who shouldn't get it. But Ben gathered the data and said, let's put it out there and see whether we do any good. Now, these aren't just my onlays. Some other people have been foolish enough to do this operation, so these are other people's onlays. So what Ben does is a matched cohort study looking at the onlay, what I call sutureless onlay, versus the sublay. You can see we looked at the time, the BMI, hernia width, and the ventral hernia working group width. To get a power of 85%, Ben needed 87 onlays and 174 sublays to get a power of 85%. And that's just the method of and again, we're looking at surgical site infections, okay? There were 91 patients with an onlay and adhesive group. There were 171 patients in sublay. You can see the different types of sublay. Everybody does a little different thing, but you can see the different types of sublay. Well-matched groups, you can see percent women, BMI, current smoker, diabetics, they were all very, very similar. Here's the results. Surgical site infections, no statistically significant difference, 5% onlay, 3% sublay. Surgical site occurrence that required a procedural intervention actually was more in the sublay group than the onlay group that required procedural intervention. Here's the results. Surgical site occurrences with the onlay, sutureless onlay technique, 12%, 16% with the sublay, and you can see the onlay compared very well. No statistically significant difference. Real-time data, as Mike said and Ben said. So simple and easy. It's not for every patient, not for every hernia. Immediate fixation of an inexpensive piece of mesh. The stress is taken off the midline closure very quickly. You can do it on other hernias. This is what Chevrolet said. Fiber glue allows immediate fixation of the prosthesis over its entire surface, giving the effect of an instantaneous repair and thus avoiding a delay during which many recurrences occur. Thank you.
I'm sure there's no comments after that.
You said you wanted to wait.
No, we'll wait. You guys will get your chance.
Thanks, Guy. I also want to thank Guy for giving me his cell phone, and I think I bug him, about once every 2 weeks on how to perfect that technique. But thanks again for your attention. I just want to impress upon everybody, these are simple questions that we wanted to answer with some really good data, and we're going to continue that theme on trying to answer simple questions to make our lives better for our patients. So the thing we were interested in looking at was, we had a couple of talks today on prehabilitation, ERAS protocols, and how to get your patients set up for success in minimizing complications. So one thing we wanted to look at was chlorhexidine scrubs in ventral hernia repair. Is this a helpful or a harmful thing? I'm just kind of curious here, just to show of hands, who here in the pre-hospital setting for their abdominal reconstruction patients administers or recommends a chlorhexidine scrub for their patients right now? Yeah, so I think this is going to be a really, really important point to talk about here. So this is my disclosures. I have research support from Bart Daval. I'm a consultant to Arisa Medical and also to Pfizer. So a little bit of background. Chlorhexidine gluconate is the most common pre-hospital anesthetic that we administer to surgical patients. And it's a topical anesthetic. It significantly reduces microbial skin burden. It's been shown to reduce SSIs in multiple surgical subspecialties, including ortho, cardiothoracic, and obstetrical procedures. And as mentioned, it's been incorporated into many preoperative rehabilitation protocols as a means to reduce wound events. And as you can see there, this comes in many different flavors, shapes, sizes, colors, and it's pretty widely used and pretty cheap actually. So our rationale for this very focused question was we aim to evaluate the use of pre-hospital chlorhexidine gluconate scrub in patients undergoing ventral hernia repair and its impact on 30-day postoperative wound outcomes. The population we looked at were all patients in the QC undergoing ventral hernia repair. We split them up into two comparison groups because we collected this variable and defined it prospectively at the inception of the Quality Collaborative into those who got pre-hospital chlorhexidine scrub and those who did not get the pre-hospital chlorhexidine scrub. And our outcomes were the typical 30-day post-op wound events, including SSIs, SSOs, and those requiring interventions. So we had two different analyses. The first was a regression analysis where we predicted the odds for wound events, controlling for multiple factors to try to balance the playing field. And the second analysis was something similar where we used a technique called propensity score modeling to try to further kind of level the playing field. Just a little bit of word about that. This is obviously not randomized controlled data, and there's no question there is a role for randomized controlled data, but I think what this is real world data. And so the good thing about that is it's real world data from you and me, people who operate on patients on a regular basis. But the problem with that is trying to make comparisons between two groups is often difficult because you can't get balanced groups. This is a method to try to basically level that playing field by making it more of a comparable group here. So what are the results? For the first analysis using the regression model, so basically we had just under 4,000 patients that met inclusion criteria. And here you can see on the left side part of the slide are the characteristics of those who did have pre-hospital scrub given, and on the right side are those who did not have pre-hospital scrub. You can see there were fairly comparable groups in terms of age, percent women, body mass indices, current smokers, diabetes. Incidentally, there was actually a higher proportion of patients with COPD who did not receive pre-hospital scrub. This is important because COPD also has turned out to be a risk factor for wound events, so maybe a little sicker population in those who didn't receive the scrub. The mean hernia size was about the same. We were able to detect a difference because we had such high numbers, but essentially no clinical difference, 6 centimeters and 5 centimeters. Probably more complex cases occurred in those who did receive the scrub compared to those who didn't, as reflected by OR time, and also slightly higher rates of myofascial release of various sorts. If you look at wound class, there was actually a higher percentage of patients who were class 2, class 3 wounds and those who didn't receive the pre-hospital scrub. So what are the results? In the unadjusted analyses, if you look at surgical site infections and surgical site occurrences, there was really no difference in patients who got scrubbed or didn't get scrubbed. Surgical site occurrences, there was a higher proportion of surgical site occurrences in those who did receive the pre-hospital scrub. And if you look at the interventions that were done for that, again, no difference between getting the scrub or not getting the scrub. So if you put this all into a regression model, again, to try to kind of balance the playing field here, some interesting things began to fall out. The first was that if you did have the pre-hospital chlorhexidine scrub administered, there was actually a higher odds of wound events in terms of surgical site infections and surgical site occurrences, but not a higher chance of getting one of those that required intervention, but nonetheless higher wound events. And now what we did was we took kind of a similar model and added in this, this variable called propensity score, which tried to help level the playing field. And essentially what this slide shows is the top is the results without the propensity score included in the model, and the bottom is the results with the propensity score. And essentially, it didn't really change much. It told us that we had fairly reasonable comparison groups, and then basically we're actually seeing what we think we are seeing here. So I think in summary, we find here that pre-hospital chlorhexidine scrub does not reduce wound events after ventral hernia repair and likely increases surgical site infection and surgical site occurrences. Well, the immediate question then is, you saw how many people raised their hands. In fact, I raised my hand because this is part of our protocol as well. But then you kind of ask, is there a plausible reason why this is the case? And I think we actually are beginning to see that there may be a reason here. So what we're seeing here is really the first epidemiologic evidence that alterations of skin bacteria may actually be harmful. And it's worth kind of mentioning this because I think this is going to change the way we approach decontamination and some of the potential side effects of that. So interestingly enough, chlorhexidine is bactericidal. A 1-minute exposure to that concentration results in a greater than 5 log reduction in the selected bacteria. So basically, it's good at killing bacteria. But the question is are we killing good bacteria? Incidentally, and again, in full disclosure, I am not an expert in the microbiome or microbiota, but I have experts at Vanderbilt who are, and after discussing with them, certainly the human skin is the largest organ in the human body. The skin microbiome is really critical for the host immune response to protect us from bad things happening to our skin. So there are many organisms in the skin that provide vital functions that the human genome really haven't developed. And this type of symbiosis we think is probably important to preventing wound infections post-op. There's really a balance between a host and a microorganism that occurs all the time. We've seen this in the colon, and now we're kind of beginning to see this in the skin as well. But I would propose out there, are we really guilty of this? And that's we're trying to dig a simple hole with a humongous rock that's kind of having unintended consequences. And I think these type of pieces of information and studies are really going to make us rethink about how we approach something as simple, potentially, as wound infections and wound events. So, thank you.
Okay, we're going to keep moving on. The excitement I hope is palatable for all of you guys. This is what happens when we actually come together, work together, and share information. Is everything you're meant to? We're going to do the questions at the end. At the end means after the end.
Moshe at the end.
We're going to do it at the end. At the end. Sorry, we'll get to that, I promise. When we all share and collaborate, everything you've been told might actually just be wrong, and you might even be hurting people. So I hope, as we continue on talking about hurting people, we brought Alfie Carbonell up here. And we're going to let Alfie talk about one thing that doesn't have to do with the robot, and it's going to be something as exciting as drains.
So thanks, Mike, for that great introduction. I'd like to thank the co-authors for my help in this study, and particularly Ben for a lot of hard work that went into it. Just so show of hands, who thinks drains are good? All right, show of hands, who thinks drains are bad? All right, good deal. We'll see. So this is a disclosure slide honorary receipt from who you see there, not pertinent to the discussion. So a little background, I think this topic is controversial. I think it's about 50-50 in the room. I'm not sure. I can't count all that quickly or that well. I am from South Carolina. Drains, there's a thought that drains cause infection, and then there's a thought that drains are helpful and they reduce seroma. And in fact, I went through a couple phases in my life. When I first came to Greenville about 8 or 9 years ago, I had been on a streak of not utilizing drains, and I had 2 back-to-back significant wound complications, and I immediately went back to using drains, and I have not stopped using drains, and I leave them in until they're draining less than 30 cc's. And again, that's one of the things, a lot of us practice by anecdote. We have 1 or 2 bad outcomes, we completely change what we do, and that's the way it is, and I think that's one of the potential downfalls. And I think that's why this information is really interesting. Certainly the data is lacking. There are literally 4 Cochrane reviews on this, and all of them say that there is insufficient data to make any recommendation because there's only one trial with 25 in one group and 30 in another group trying to compare drain versus no drain for incisional hernia repair. So it is absolutely an unanswered question, and certainly looks like it's an unanswered question for the people in the crowd. So we sought to see what the story was. We queried the database for open retromuscular incisional hernia repairs. So these are open retromuscular repairs. These aren't onlays, these aren't intraperitoneals, these are open retromuscular Reeve Stoker repairs. This is a cohort study where we compared patients who had a drain placed directly on top of the mesh or not. It's pretty simple. And we looked at the 30-day outcomes, which are the usual players that have been discussed by the others, SSI, SSO, and those requiring procedural intervention. Analysis 1 was a multivariate logistic regression to look at odds for predicting wound events, controlling for multiple factors. And then a second analysis, because there were such disparate numbers, was a way to try to control and, as Ben says, level the playing field and match patients on gender, elective status, the hernia repair, wound class, hernia grade, and hernia width. And we'll go over that. So 1,100 patients qualified for inclusion in this. We had 915 who had drains placed. Clearly a lot of people placed drains. 185 that did not have drains placed. And you can see the real thing that sticks out is that drains were being placed in more obese patients and in operations that took longer to perform, and in patients who had had extensive myofascial release. By definition, we did a Reeve Stoker, but when we added a TAR release in that posterior space, a posterior component separation, there was a higher amount of drain use. So clearly a more complex patient population. When we looked at just that initial analysis, we saw that there was no significant difference in the drain versus no drain as far as SSIs were concerned, but a significant difference in surgical site occurrences in favor of not utilizing, or rather, I'm sorry, in favor of utilizing a drain to prevent surgical site occurrence. When it came to procedural intervention, there was essentially no difference. So those patients, although they had increased SSOs, did not require procedural intervention. When we look at the odds ratio and what predicts SSO, SSI, and SSOPI, the only thing that fell out was that drains were actually protective of surgical site occurrence, but not of infection and not of things requiring procedural intervention. When we looked at a breakdown of what these SSOs were, because it's a very large category, they were mostly seromas and cellulitis, right? It sort of stands to reason. Leave a drain in place, it decreases the amount of seroma because it's draining the seroma. But obviously these were sort of, you know, a little bit of a different patient population and a size discrepancy. So in an effort to control for that, we performed a 2-to-1 match, which was based on gender, the elective status of the operation. So these were not, you know, controlling for emergency, non-emergency operation. Wound classification, which is important. Hernia grade and hernia width, obviously as surrogate markers of complexity to try to control for that as best we can. So we ultimately ended up with 357 patients with retromuscular drains and 181 without drains. And still there seemed to be a little bit of a difference in that the patients who had drains placed still had an increased operative time and an increased rate of transversus abdominis release or posterior component separation. So maybe a surrogate marker for complexity of the procedure, although really they were matched on defect width, so I don't know exactly what that means. When we look at the ultimate outcomes here, we see no significant difference in this matched analysis as far as surgical site infections, surgical site occurrences, and those requiring procedural intervention are concerned. Again, in the matched outlook. So, in summary, I think what we can surmise from this data is that drains are being used increasingly, obviously, in more complex cases, and we see the marked difference in the volumes of drain use, as you saw in the data there. They are being used in patients with a higher BMI, when you're in the operating room for a longer amount of time, which is assumedly a larger dissection, a more complex operation, and the concept of utilizing more transversus abdominis release, which may or may not be a surrogate marker for defect width, but it may just be complexity of the operation because we did match for defect width. And drains, in fact, are probably protective against SSO, particularly cellulitis and seroma. And so I think in summary, we can conclude that drains certainly do not increase the risk of wound complication like Harlan Stone, who's a giant in surgery and professor emeritus in our department believes that drains are evil in any way, shape, or form in any operation. So I love proving the old man wrong, and we've got some pretty large data that has really never been brought to the forefront to discuss this concept and argue with it at M&M. So drains certainly do not increase the risk of wound complication, and thus they're safe for open retromuscular sublay incisional hernia repairs. So, thank you.
Glad to see that Alfie is just as passionate talking about drains as he is the robot. Next speaker is Jake Greenberg. He's an associate professor of surgery at University of Wisconsin. Jake is going to highlight one of our efforts of what really kind of separates this effort out of not being just a registry or a data collection mechanism. We're actually trying to effect change here, and he's going to talk about a very, very critical part of that in surgical coaching. Jake.
Thanks, Mike and Ben. These are my disclosures. I will mention Project Adopt, which is the project for which we received some funding support through Medtronic, but the project itself was product and device agnostic, so it's not completely relevant. I will also acknowledge my wife, Caprice Greenberg, who is really the brains behind this operation, who's the person who's done the lion's share of work in this field. She'll actually be arriving tonight around 8:45, so if you see her anywhere in the lobby, please feel free to tell her that I acknowledged her and also spoke highly of her, because I think it will help my marriage. So that would be much appreciated for me. So surgery is a complex skill and a complex task, and like all other complex skills and tasks, there are variations in performance. This is data that comes from a study of the Michigan Bariatric Surgical Collaborative, where everyone was asked to submit a video of their representative laparoscopic Roux-en-Y gastric bypass. The videos were then, in a blinded analysis, rated by their peers, and they were scored on their average rating. Now, we all know that there's variability in surgeon technical skill and surgical performance, but what this study showed was that that variation in performance actually leads to variation in patient outcomes, and the better performers had better patient outcomes compared to the worst performers. That's probably something that we've all intrinsically and inherently known, but this was the first time it was really kind of proven in a scientific fashion. And this is one of the many reasons why many of us feel like we need to improve our performance. And there are a variety of different approaches currently utilized for performance improvement. We have regionalization of care and selective referrals to high volume centers. We've created systems of care and processes of care to try and improve performance and performance measures. Many of us do fellowships to try and improve our technical skill set, and we've subspecialized our practices to get better and better at fewer and fewer operations. We've also formed quality collaboratives like this one, which focuses on improving performance and improving patient outcomes. And we've used social media to all learn together as well. So we've been working on performance improvement, but I think one other thing that's been introduced recently is this idea of surgical coaching. Now, many people first read about this in Atul Gawande's paper in the New Yorker, where he talked about top athletes and singers having coaches, and should we have coaches in surgery as well. And then again, my wife's group worked to publish sort of the first surgical coaching paper looking at the use of video-based coaching for continuous professional development for practicing surgeons. Now, the goal of surgical coaching is to get us out of this area of arrested development, which is where most of us practice. We get very comfortable at what we do, we keep doing it over and over, and we kind of get into this arrested development phase. And the goal of a coach is to try and transition you from that phase of arrested development up to expert performance, which is where we all strive and hope to be. Now, it's been shown that this works at a variety of different levels. So this was a study of medical students who underwent either regular didactic curriculum to perform virtual laparoscopic cholecystectomy and then porcine laparoscopic cholecystectomy, compared to medical students who were surgically coached to do so. And what they found was that at each individual time point, the coached students outperformed those that just received regular training. Interestingly, they took longer to perform the dissection, they just performed it better. This also was shown in trainees. So this was a study from the University of Toronto where they took surgical residents and surgical fellows. They gave them their regular training, so they would be on the MIS service, get the regular didactics, the regular curriculum for MIS, or they gave them complex surgical coaching. So they did debriefing, they did video-based review, and they did post-surgical analysis with their coach. They then watched them do laparoscopic jejunal-jejunostomies. And both were reviewed by outside reviewers on their OSAT skills, so the Objective Structured Assessment of Technical Skill, a bariatric specific Objective Structured Assessment of Technical Skills, and also reviewed surgical errors. And all of those outcome measures improved significantly in the group that received surgical coaching compared to the regular techniques. Surgical coaching also impacted the way that people felt about their own performance. So they asked the people that participated in this to self-reflect about their own performance. And what they found was that those that underwent coaching were better able to self-assess than those that didn't. So it provided some insight into their own technical skill and performance as well. Interestingly though, we found that peer coaching is a little bit uncomfortable for us as surgeons. It takes us out of our comfort zone. We're used to doing the same thing the way that we do it. When you want to function as a coach, you have to be comfortable doing and looking at things in a different way. You have to learn that other techniques are acceptable, and you have to see the value of those. So it's a different mental model that challenges a lot of us as expert surgeons. But being a good coach really requires that you're able to and willing to explore those different techniques. And so to try and figure out how to train a coach, we worked with coaches. So we went to the athletics department where Brett Bielema was our football coach before he left for Alabama, Bo Ryan before he retired. We went to the School of Music and found professors in the School of Music and School of Education and worked with them to figure out how we would train someone to be a surgical coach. And through that work, we developed the Wisconsin Surgical Coaching Framework, which is a framework that can be applied to pretty much any situation in which you would like to be coached. So it can be video coaching versus live coaching, focusing on a variety of different cognitive, technical, and non-technical skills. And we've subsequently implemented that into 3 coaching projects. The first of which was the Wisconsin Surgical Coaching Project. And this was a quality improvement initiative that was run through the Wisconsin Surgical Society. Coaches were peer nominated. And essentially all 10 coaches were senior members of the Wisconsin Surgical Society who were very well respected throughout the state. All of those coaches underwent 4 hours of coach training through a resource manual and a live coach training process. And then participants were asked to video record operations and meet with their coach once quarterly to review it. They repeated this quarterly for a year, and the results are actually in submission now, I think, to Annals of Surgery. Our second coaching project was the Michigan Bariatric Surgical Coaching Project. This one was to design and implement a video-based peer coaching program throughout the MBSC. And this was focused really on performance of sleeve gastrectomy and improving risk-adjusted complications and outcomes following that procedure. Now, for the Wisconsin Surgical Coaching Program, we peer-nominated coaches. For this one, we took the top performers. So we took the people who in the MBSC were viewed as the top performers of sleeve gastrectomy, and they became the coaches to provide expert coaching to the more junior and other members of the MBSC. The one interesting thing about this is that they mandated that everyone perform. So basically every member of the Michigan Bariatric Surgical Collaborative is currently undergoing surgical coaching for sleeve gastrectomy. Our third project has been Project Adopt, which is a project focusing on converting open inguinal hernia surgeons to laparoscopic inguinal hernia surgeons. So at UW, we created a curriculum and a program to try and guide people through that process. We recruited 3 surgeons who were all open inguinal hernia surgeons. 2 have gone completely through the process. Both have adopted laparoscopic inguinal hernia repair, specifically TEP, into their practice. Our third is currently still going through the process, but is doing quite well as well. So we've had very, very good success with this project so far. And that is what led us to try and implement a surgical coaching program for the AHSQC. It's going to be focused on performance improvement in ventral and incisional hernia surgery, but we view this as really the beginning and something that could extend to inguinal and really all other types of hernia surgery as well. For this program, we're focusing on coaching through 2 different means of feedback. The first will be traditional surgical coaching, where again, you'll meet quarterly with your coach. Since we're a national group, this will be through WebEx. But you'll have 1-hour quarterly sessions with your coach to go through your performance and give you meaningful feedback. The other arm will be looking at asynchronous video-based feedback. And for that, we're going to be using this device called Surgis. This is a web-based service that can really help, I think, improve people by giving them feedback on their cases. So with Surgis, your coach can review your video a little bit faster. They can play it in real time if they want, or they can speed it up. And they can provide you real-time comments on your procedure. So as soon as the coach starts typing into the video you've uploaded, the video pauses so that you can get that meaningful feedback in a time-sensitive fashion. They'll know exactly what you want to focus on, and they can give you feedback for that specific area. Additionally, built into Surgis, there are some metrics and rubrics that we can use as well. So OSATs is in there, goals is in there, a lot of the standardized materials that we use to grade residents and look at people based on performance are included in this as well. So you can ask for specific feedback on how you did with mesh fixation or closure or dissection. So you can break it down to be very, very complex. And the nice thing about this is it's much more convenient. It can be done at any time. It doesn't have to have two surgeons trying to work their schedules together. And so we're going to be comparing these two. And I think this will really be a helpful thing going forward for surgical coaching. So we're in the opening phases of this. We already have 8 of 16 participants signed up to be coachees. So if you are interested in this program, I urge you to come and talk to me right after this, or email either myself, Shelby Dunstan, or Sudha Kwame. For this, we did ask for peer nominations from coaches during our last quarterly call. And we received 5 peer nominations, and they have all agreed to be our surgical coaches, and they're listed here: Conrad Balisaire, Alfie Carbonell, Kent Kircher, Brent Matthews, and Michael Rosen. So a phenomenal group of coaches. And so I urge anyone that's interested in participating to sign up. I think it'll be a great thing, and again, I think it's just the beginning. So I do think that surgical coaching has a significant potential to improve performance throughout surgical careers. And one of the real benefits of it is it incorporates adult learning theory and is very timely and very helpful for you as someone who's interested in improving your own performance. It's going to improve quality. I think it will improve safety and outcomes as well. And I really do think that this is just the beginning. So again, with any interest, just feel free to email or call anytime. Thank you.
Let's have all the speakers come back up. We're going to take about at least 10, 15 minutes. I'm sure there's some questions. Yes. Can we get the mics on?
Hello, William Pope from Wilmington, North Carolina. This question is for Ben Project, but maybe for all of you. Bruce Ramshaw in the audience, maybe for him. So how are we going to deal with information that we get from this collaborative that flies in the face of other information, such as chlorhexidine, that has been proven in other fields to be very worthwhile? It may not be worthwhile in hernia. So that's one question. So what if we get congruent data? Which one do we believe? And then second of all, if we believe that, which I think we do, how are we going to, what's a good way, if you've done this in your hospital, because we use this for every surgical patient, to say, okay, how do you get that? We're not going to use this for hernia patients. Is there a good way to do that for our collaborative? Does that make sense?
Yeah, it does. I think, as far as if you have information that kind of goes against the grain of what we have known and accepted, I think, first of all, you have to kind of be very critical about the information and see, hey, is this something that we believe based on data collection, data assurance process? In other words, are we collecting the data to the best of our ability? And I think, and certainly this is a biased response, is, yeah, I think we are doing the best we can in terms of getting this type of registry information. But certainly, and I think the other part of that is also you have to see if, is the analysis correct? And also, is it a clinically meaningful difference? If you looked at the actual numbers, the absolute difference in surgical site infections wasn't all that much. It was just over 1% or so. But still, it's heading in the opposite direction that we thought for a long time. So I think as best as we can determine, that's pretty reasonable evidence. I think you do have to ask the question, though, could this ever lead to a randomized trial to give us maybe even more definitive information? And I think a lot of the answers for the subjects we talked about is, no, it's not going to lead to a randomized trial. I mean, if that were the case, we'd be talking about randomized trials here all the time, but we know that that actually doesn't happen in our space because there's not a lot of reason for that to occur. So I think this is the best information we have. Sure, it certainly has limitations. And as far as how to kind of bring this to your hospital, I think that's the power of being a member of this collaborative. Here you have access to this type of information. You can go to your hospital and say, hey, look at this population. This maybe isn't the best thing that we're doing. But I think it brings up all these questions, and I think it leads to a really good discussion.
I'm going to tag one thing on that. I think this is really actually exactly what the collaborative is supposed to do. Because let's take the opposite of your question. a randomized controlled trial comes out and says chlorhexidine is not good, it's appropriately powered, and you believe it. Then you go home and you change your practice to stop using chlorhexidine. If you're not part of a collaborative and actively tracking your data, you actually don't know if that trial was actually appropriate for you. So this is the exact point of that circle that we talked about earlier. And it's not to say that every time when we do the analysis, we're going to get it right. But what we're going to do is analyze the data real time. We're going to feed it back to you guys. We're going to hopefully change your practice, and then we're going to measure it again. And we're going to come back in a year or two, and if we start to see a peak and we were wrong, we'll know that, and then we change. So I think that is the power of this. Next question.
The scrub remind me the pre-hospital scrub, the pre-surgery shave. It's exactly. When we start to change it between shaving on the operating table or to do it spray, the infection rate increased. So it's quite the same, I don't know why, but do it as simple. Don't try to be too sophisticated.
Yeah, I think, that's why we're looking at this, in a real world setting, because there is going to be a lot of that type of variation in, when the scrub is administered, all those type of things, which honestly we have, we don't have a way to track because we haven't included all that information, but no, I think it's a very good point.
But I would add to you, when Ben showed me this data, the first thing I said is, oh my God, our first analysis is the opposite of everything we've been taught, we're screwed. So, but when we looked into this deeper, interestingly, you guys assume that there's so much data out there that supports chlorhexidine scrub because your hospital hands you a blue bottle and you're told to go do it. If you actually look a little deeper, all of the level 1 evidence, which is high level in New England Journal of Medicine, is orthopedics and cardiac surgery. There's nothing on the abdomen and GI surgery related. And this is really the first large scale analysis of that. So I think it just shows to step back and challenge that just because somebody said it's okay and the quality department said it's okay, they might not know either.
Another one, regarding the drain, closed system drain. It's not the same. We did in our International Endohernia Society guidelines recommendation, we recommend to use a closed system drain on tap repair, groin tap repair for 5 to 6 hours post-op. And it was experience of some parts for many years that we use it to improve the outcome, to reduce the edema, groin hematoma and other. So there was a double-blind control study that compared between no drain, no closed system drain, and with closed system drain for 6 hours post-op. And amazing. It's a groin hematoma that was 17.8% without closed system drain, reduced to less than 0.5%.
Yeah, I think that's intriguing. I must admit, I'm not right. And this is groin hernia surgery, and I thought we had settled that debate with open, big inguinal scrotal hernias. And I must admit, I'm not aware of a TEP repair. I cannot imagine out of anyone in the room that does TEPs, do they use closed suction drains for a few hours after surgery. That's out there, but I like it.
But I hope you feel vindicated.
So there's going to be going live here, hopefully within a year or a little bit after a year. There'll be an inguinal hernia module for the AHSQC, and once we have 4,000 or 6,000 inguinal hernia patients, and we've got drains, no drains for TEP, maybe we'll be able to answer this with a little bit more definitive data. And the reality is, you did a randomized controlled trial, and I assume it was single center. But when we take randomized controlled trial data and go out into our practice and use it, we don't know. Certainly I don't remember what the inclusion and exclusion criteria were. We just practice what we do, and we apply it broadly to everyone. And that's probably why RCT data doesn't necessarily pan out in the real world. I hate to keep using it, but it's true, it's the real world, and the QC is the real world, and it's people making everyday pedestrian decisions based on experience and bias, and we got some really neat data on drain. I mean,
we're gonna get to the next question, just so we have time. You can go back to the back and wait again. Next question.
Hey, Jack Clark, I have a question for Dr. Veller. I'd like to join Dr. Rosen in finding an alternative for the retromuscular and TAR repairs, but I have a question about how you got those 10-centimeter defects closed before you put your mesh on and doing some kind of release. As I recall, I saw Dr. Chabrel give this talk many years ago in Miami, and I think he used only the anterior fascial rectus overlap, which was actually described many years ago by Velti and Oidel. Right. But I gather from Dr. Bauer that he may be doing some kind of release. I wonder if it's the standard Ramirez anterior fascial release with or without the posterior rectus sheath, which Ramirez also described, and whether or not you're getting any skin slough from that, because I had a very high incidence of that when I used it.
Sure. As I mentioned, you have to be very careful until you do this in, and that's what you learn when you first start doing this. You don't do it in smokers. Don't do it in people that have had aortic aneurysms because they're collateral, so their abdominal wall has been taken. You don't do it in people with big, thick, huge pannus like Gary operates on all the time. So patient selection is proper. And then we do a classic Ramirez. If you read Ramirez's paper, it was a stepwise technique. The skin flaps first. If that didn't get your midline closed, then you incise one posterior rectus sheath, posterior rectus. That didn't work, you do the posterior rectus on the other side. If that didn't work, you do the external oblique on one side. If that didn't work, it was a stepwise progression. We do that exact thing.
But I want to add one thing to what Guy just said too, and this is key. That data you just saw is not just Guy. It's actually 9 surgeons in the QC that perform onlay at very different incidents of doing that. So that really actually, to me, is the most powerful aspect of it. I'm sure Guy had a lot of them because he's a big proponent of it. Some of them are mine, some of them are other people's as well. So I think, it's the real world stuff that makes it different.
Great, thank you.
Ben, this is for you. I'm sure when you presented the chlorhexidine, you expected a lot of questions. So my question for you is, you didn't say if they were lap and open or just open.
Yeah, these were just open.
Okay, because that's important, obviously, because the lap patients, I don't chlorhexidine my lap patients. The other one is, did you look at IBAN usage?
No, we did not look at IBAN use.
Because there are other things we do besides chlorhexidine. We do Iovan usage, we do peri-op antibiotics, we do Bactroban, nasal Bactroban. So there's a lot of things that we do use for the high-risk patients, and I think when you actually publish this, you may want to look at that and stratify for that, because that's a huge statement that you're making that it's important to make sure that it's apples and apples.
Yeah, no, I think, again, that's a great point. I think this brings up kind of a bigger issue, and that is, we're just assuming with all the studies that we just presented so far that one single tweak leads to a humongous change. What you highlight is absolutely true. I mean, in reality, it's probably 6 or 7 different things that ultimately kind of affects things. In these type of things, it's just a single outcome of wound events. So I would actually argue that that's the whole reason why we're doing this, is so we can follow this information over time. And if we've kind of had these comparisons of randomized trials. Well, one of the difficulties in randomized trials to answer very specific questions is you're assuming that changing one thing affects a whole lot of different things, when it might be just the opposite. It may be changing 10 things all in succession actually has an impact one way or the other, and that's what we're trying to sort out, but you're absolutely correct.
Greg?
Hi, Greg Devine from Chicago for Dr. Kirpada, and for your comment, Mike. While I agree that changing the microbiome is not a good thing, and the chlorhexidines is not a good thing, perhaps the bowel preps are mechanical to decrease the bowel size to make the surgery go easier for the surgeon and for the patient post-op, and so you don't have the intra-abdominal pressure pushing on the stitches and causing early suture pull-through. So when a surgeon says you can never do a bowel prep, there may be other reasons, and when you write your paper, you can say, well, you're not going to do it to decrease SSI in case you have an enterotomy, but there may be other reasons that a bowel prep is beneficial in a hernia repair.
David?
No, I think that's a good point. I think the key to what was sort of presented is that if you're going into this operation and you're considering bowel prep as part of your way of reducing surgical site infection or surgical site occurrences, then you should change that practice. If you're doing it in an effort to try and reduce valve size to make sure everything can fit back in when you close things up, then that may be something different. But we've also shown that with a valve prep, you may have a higher rate of surgical site infection and surgical site occurrence, so you have to weigh that risk-benefit of a smaller valve versus a higher risk of a surgical site infection.
The statements regarding your data were very strong and
But great.
maybe not totally
Great.
appropriate.
Hold on. So
You
hold
can't
on.
say
Go back
no
on
valve press
the
for the rest of the, the
No,
rest of
hold
mankind.
on. So first of all, your statement that giving a valve prep reduces valve diameter is based on nothing. In fact, many patients with hernias that are incarcerated are semi-obstructed, and I would argue right back to you that giving a valve prep makes more edema of the valve, more distension of the valve, and actually, the main reason I don't give a valve prep, interesting enough, I'm actually surprised by that comment, it's not because of the SSI reduction, because I was shocked by that too. It's because I think they get an ileus after, they tend to be a little bit more distended, and it's much more difficult. Now, we don't have that data here today. I'm not going to make that claim up here now, but I would tell you, how many people think, let's just, with our
Well,
collab,
let's just wait, one comment. It depends on the type of valve prep. A big,
Okay.
Go Lightly valve prep gives you swollen valve, and I
Okay.
agree. 3 or 4 Ducalax tablets and a half bottle of mag citrate, so they have a couple of good valve movements to make the colon decompressed. That's also a valve prep, decreases intra-abdominal pressure, and that's what we used to do for aortic surgery, open aortic surgery. You don't want to be doing an aortic tube graft and getting all this bowel in your way. You want shriveled up bowel so that you can work on it easier and can retract it gently out of the way. So it's old-time general surgery.
we're gonna agree to disagree. There. Which we've done many times in our lives.
I just have a quick comment about the CHG and a question for George. The comment is that I wonder, and this is awesome, by the way, this is really good. One of the things about the CHG application that we might want to flesh out, since this apparently is a pretty strong statement, is that there's scrubs and there's some dry cloths that you can use. And just like the difference between a shaver and a clipper, we might be actually fleshing out something. If most people are getting a scrub instead of one of these dry cloths, it might be a difference. I mean, obviously we have no way to know, but it might be something to look into. And for George, when the FDA is considering approving new mesh, you guys say it's safe and effective. Does effective mean that it works? In other words, it works in our hands and in the operating room, or are you trying to flesh out long-term outcomes such as recurrence?
But, that's part of the problem. We depend very much on the data we get on the so-called predicate mesh. If the new mesh is very similar in terms of technology, and we get tons of data on these meshes, it's hard to say that they're not equivalent, that they're not going to perform similarly. But in fact, they might not perform similarly. And I think that's where the post-market follow-up is going to be very important. You see, if getting an early signal that we're having a problem is extraordinarily important, because more often than not we get late signals when the problem is very widespread, and that's where we need to get better.
But George, just to for everybody to understand, when you approve something, you can approve something for safety only, or safety and efficacy. And often 510K is for safety, and then the onus is on the people out in this room to assess for efficacy. I think sometimes, correct me if I'm wrong, but sometimes that disconnect of what we think the FDA is doing and what you think we're doing, I think every mesh on my shelf has a randomized controlled trial from some country with hundreds of people that supports that it works, but that's not actually correct, right?
That's correct. We're looking primarily at safety. In fact, one of the first things I do when I look at a submission is I look at the track record of the predicate mesh. How's it doing out there? And I use that in my analysis. But safety is tantamount to everything we do. That's the prime objective.
Just a very quick point about Fitzgibbon Simone. I'm following up on the next two questions. I probably should have sat down because they were sort of asked them, but on the subject of the valve prep and the chlorhexidine scrub, as a substantial contributor to this collaboration, I'm embarrassed to say it. I sort of was confused
I think when I answered the question, does a bowel prep consist of a formal bowel prep, when you say mechanical bowel prep, or if you just give them a laxative, does that count? What if you just give them a laxative? Some magnesia, is that a bowel prep? Because that's the way I answered the question. If I gave them anything, no go, I answered it, yes, I gave them a bowel prep.
I believe so.
And then the same thing with chlorhexidine. Our routine is to do the scrub right in the pre-operative. The nurses give them a package and scrub themselves. Is that count as pre-hospitalization, or is that should I put no or yes on that one on the box?
So I think this brings up kind of a big issue overall, is how do you define, all this as we're looking at. So yeah, I mean, it is up to the individual surgeon or surgical team checking that box. Is their interpretation is that they did or did not give a bowel prep or do the chlorhexidine scrub. We have some ways of coming, basically, narrowing that definition down in the interface itself with the hover boxes and that type of stuff. But in the instances that you mentioned, yeah, we do leave quite a lot of latitude on whether or not you thought a bowel prep was given or not, whether or not you thought pre-hospital chlorhexidine was administered or not. So I think the answer would be yes in both those cases. It's also interesting to note that I think we rely on your own clinical judgment in some respects with some guidance in the interface itself that tells you whether or not you should be checking yes or no for these things.
I would just say that the value of this kind of a session is that we can refine these kinds of things, which I think makes it so much more powerful.
Was the use of bowel preps in any way correlated with inadvertent bowel injuries, so that you saw that surgeons who tended to use bowel preps, in fact, had a history or an ongoing history of inadvertent injuries? That's my first question. The second is, for Alfie, is that you said drains didn't hurt you. I wasn't clear because you said that. Did you mean drains help you in decreasing? Is that significant? Because you only said it one way.
Yes, I'll take the drain one before I forget the question. But on initial analysis, on initial unmatched analysis, controlled for several variables that the QC controls for, there was a protective effect of drains for surgical site occurrences, namely cellulitis and seroma. But there was a difference in complexity of the patient. So when we attempted to control for at minimum defect size and BMI and some other things, there appeared to be no difference in drains or no drains. So take that for what it is. If you look at the use of drains, there was an inordinate amount of drain use, and they were more obese, and they had more transversus abdominis releases, and they had a longer operative time. So I think the real take-home message for me is we have to stop saying, I think we need to stop saying that drains are actually hurtful, and you put drains directly on top of the mesh, you send them home with antibiotics. That's the plastic surgeons doing. We send the patient, I was like, no, leave the drains in place. They're directly on top of the mesh. They're probably protective of SSOs. We use them in more complex patients. They're probably protective of SSOs, but it's sort of on you. You can probably get rid of them if you wanted to. What I typically do in my practice is I take them out in about 7 or 10 days when you're draining less than 30 cc's, which for people from outside the city is difficult for them to get back. So it becomes a quandary of how am I going to manage that drain? Where one of my partners, Dr. Cobb, removes them before they leave the hospital at a much higher drainage volume than I do. So I think that I'm going to probably be able to compromise and adopt his strategy and let patients go home without a drain. So now it's one less follow-up they need to come do, and I'm going to have to deal with, am I going to have an increased rate of SSOs in those patients? But I know it's probably right on the cusp. There's probably a benefit to it, but there's certainly no harm from it.
If I can say one more thing. Because from the patient's point of view, the fact that it does no harm is not enough. Because from the patient's point of view, the major thing they complain about is pulling out the drain and irritation. So we have to, if something doesn't do good, then my philosophy is we shouldn't be using it, not just because it doesn't do harm.
I don't think we have that answer just yet. I think we tried to answer a different question than what you just said. We tried to understand the question that many surgeons say drains cause more infections and things. And I think that's what we answered today. The other question is a little bit different, require a little bit of a different analysis. And then the last question was about enterotomies. Do we have that information?
Yeah, I can lend some info on that. So the current rate in the collaborative for enterotomies that were kind of have consequence, missed enterotomies actually, in open repairs is 1.5 per thousand, and in laparoscopic repairs is about 4.5 per thousand. It's small, it's higher, but it's small. We can't answer this in the context of bowel preps just yet. We try to do that by splitting off into the class 2, class 3 wounds and the class 1 wounds. But it's interesting because those low rate events are exactly what we want to try to begin to analyze. We're just not there yet, but we're kind of at the cusp.
Gia?
Thanks, Mike. Ben, you might have just answered my question. This is about the bowel prep study. First, I'll congratulate all the presenters and the true collaboration this represents. It's very exciting. For the bowel prep study, it was interesting to me, your analysis, that you associated the laparoscopy with an increased SSI rate, which is very different from the literature that's out there, which tells me that there's something that is not matched across the two groups. Did you do further analysis to look at that? Is it the bowel injury rate that's higher that contributed to that?
Yeah, oh, go ahead. No.
From what I can glean, it's mostly, if you're looking at surgical site occurrences, laparoscopic surgical site occurrences were higher. And I think that's more a relation to the seroma formation. So we may need to tease that out a little bit further.
I think it's likely the distended bowel from Greg Dumanian's prep. Suture pull-out, distended bowel, that's it. Okay.
Before we move on, actually, I think it's worth also saying that's one of the problems with surgical site occurrences, because it includes bad things in terms of SSIs and other intercutaneous fistulas, but it also includes more mundane things like bland seromas you're not going to do anything with. So I think that's an important point.
And that's really the difference in the drain study, isn't it? That the surgical site occurrences were higher without the drains. Is it that primarily because of seromas?
Seromas and cellulitis. And wound cellulitis. So there's a little bit more of a bad connotation with those breakdown of SSOs.
I have a question for Ben. If you really want to change a practice, would you think of pushing the analysis a little bit further? Like we do in individual patient data meta-analysis, we are looking at predefined low, medium, and high risk groups. So in order, if you have this drain discussion, why don't you look at people that have all the combination of obesity, diabetes, etc., and then look at the other panel that don't have these risk factors, and then look at the drain. Because then you might come up with an answer that in some patients the drain is not necessarily the easy part, in the easy patient, and in the difficult patients the drain is needed. And that's in the data. When you mine the data a little bit more, then you've done this far with the match controls and propensities.
But I think what's even more compelling about the drain data is that they were disparate groups, right? So the drains were being used in more complex patients, and they still had a more protective effect than in the easier patients.
No, but this is just a general remark. It's not only about the drains, it's just mining the data a little bit further, like people do in the individual data meta-analysis. We have the same problem, a lot of data in the meta-analysis, and the individual patient data, push it a little bit further and look at predefined low, medium, and higher risk group. And then you really look, this is a patient that has the same profile as in my practice, so I need, and then I have an answer if I have to drain or no, or a bowel prep or scrub or whatever.
That's fair.
Yeah, I think that's critical, and obviously you and your colleagues respectively have had far more experience in analyzing these data sets than we have over here. I think that's important. I also think that leads to further really kind of cool things you can do, like base risk calculators based on a wide breadth of population here, as opposed to a single institution. So
and it's all in there. It's all in there. You did a fabulous job. Okay.
So for the sake of time, we're going to do 2 quick questions, and then we're going to take a quick wrap up because we have the opening ceremony. I appreciate all the excitement and interest everybody's taking around.
So on Monday, when we go back to our hospitals and try to change our practice by saying, we're not going to use chlorhexidine preps, and we're asked, what's your evidence? What are we going to be able to say other than, well, I've heard it at the American Hernia Society? Is this going to be
Great question. So first of all, on Monday, the first thing you should do is make sure you join the American Surgeon Society Quality Collaborative.
Already there.
There you go. So this is what you say. This is why I did this. This is why you signed this contract. This is evidence. And I go back to them and say, we're not doing it. And if you make me do it, show me the data that says I should do this in the abdominal wall. We're going to actually, this stuff will all eventually be published as we work through it. You might have to let us catch up to it. I think it's okay to wait until you read the full paper, but don't wait too long. Yes.
Yes. Great talks and great presentations. I just had a question about the timeframes that we use to measure quality. 30 days seems too short. I work at a tertiary county hospital that we get patients 2 months out, 3 months out, a year and a half out with surgical site infections in mesh. And drains are a two-way street. And yes, they may be protected in some respects, but we see these simmering infections with mesh that needs to come out a year later that, that they're just floating in this fibrinous, pussy material.
Alfie?
Yeah, I mean, so the beauty of the QC is that it does follow patients longer, and in fact, it's going to it will decouple the follow-up from the surgeons, because one of the complaints is surgeons want to bury their own bad data, and with the QC, there's nowhere to hide. So you're right, perhaps 30 days is premature, and we've experienced 2 and 3 month SSOs, and one of the problems with NSQIP data and other abstracted data is that it's like in-hospital complication, right? When we look at our hospital's infection rate for hernia, and we look at our QC infection rate, they're different because, of course, we follow the patients in the office, and in-hospital is a completely different scenario. So I think that's the beauty of the QC, is that it is longer follow-up, and it is also decoupled from the physician, which is very unique.
Okay, we're going to take a minute here. Ben, you want to come up and we're going to do a wrap-up discussion.
Yeah, this is actually a working session to get a couple of things done, and so I just wanted to mention both kind of a way that if you haven't been involved in the QC or you are already involved, you want to get more involved. We have 2 committees, Publications and Data Use Committee, which is chaired by Corey Deacon, who could not be here, and our Variables and Definition Committee, co-chaired by Dr. Ajita Prabhu and Eric Paulai, who will be coming up here for a second. Quick word on Publications and Data Use Committee. So basically, this is a way that we vet out requests to access the AHSQC data. I would also parenthetically add, both for anyone in industry who has a new mesh or a fixation product, email that information to either myself or Shelby in terms of your FDA approval, because we want to capture all these products moving forward. It's really, really critical. Even if you're a foundation partner or not, we want to be complete about that. For data requests, it's really important. AHQC members with a minimum of 25 cases entered, including completed 30-day follow-up, have access to the entire QC data set for research and QI. You can access this and answer these kind of questions here. The way we work this is that the AHSQC Data Coordination Center, which is Vanderbilt, handles the IRB and the analysis. I think that's really important because if you're a private practice surgeon, you want to query this information, you're part of the QC, you already have the IRB taken care of at Vanderbilt, and you have analytic capability at your fingertips. I think it's really, really important. Submit the request to Shelby at the email you see there, and you'll fill out a form that kind of vets out these requests. Remember, as a member of the QC, you can access your data anytime. Real-time reports, as soon as you enter information in there, the Quality Collaborative updates nightly at about 3 a.m., and so you can get this information back to you. We have a new feature and when you can kind of log in and pull this up called these trend reports. And here you can see, you can select surgical site occurrences, it recalculates it over time. You can select different outcomes, surgical site occurrence, required procedural intervention, calculates it over time, and change these, and this again gets updated in a near real-time basis. You can access this on your own. Very quickly, if Drs. Prabhu and Paulai want to come up, just Paulai. Talk a little bit about the Definitions and Variables Committee update.
Greg, if you go home and stop bowel prepping, you can track day to day the improvements in your patient's outcomes.
Well, thanks. That's a really tough act to follow. I just want to quickly give an update from Ajita and myself from the Definitions and Variables Committee. And a quick plea, if you find something in the database that is not correct, for those of you who are entering data, if you have a question about should I be entering this data one way or the other, like the question that came up about how to enter a skin prep or a bowel prep, just email either of us and we can certainly update you on that. For most of these, there should be a hover box definition that will tell you what we consider to be the yes or no for those particular variables. In the past year, we've been working behind the scenes to add some additional information. 6 months ago at our last get-together, we had some questions about our HbA1c variable in terms of how we were collecting it. Could we find a way to enter data to specifically say whether it was checked in the last several months and what was the actual HbA1c for those of us who want to collect that information. So that is now live and active. For those people who are doing a mesh sandwich type of repair, we now have the option, this will go live, for you to be able to enter more than one type of mesh in more than one position for the repair, so we can collect that information in real time. We've had some formatting changes and some streamlining to the user interface, which I won't go over, but for those of you who enter data, you may notice that some things have changed in how you enter the data, and that was done with based on requests to make it a little bit easier for people to enter information. Ongoing work. We're going to have a modular interface to allow you to select from more than one type of hernia repair. So if you are repairing a peristomal hernia and a midline hernia and an inguinal hernia all in the same patient, you'll be able to enter that information accordingly. The patient list screen will be modified for those of you who enter your own data. It's annoying to go back to the main home screen after each patient, to then go back to the new enter site. You'll be set at the same page once you go in. And we're actively working on a new rectus diastasis variable for those people in the audience who enter data and who do plicator rectus diastasis. We're going to have a way for that information to be captured as well. We've added some new members. Dr. Jeff Blatnick and Steve Rosenblatt have been added to the committee to help us flesh out some more of this information. So again, we've got more capabilities. If you have things that you want to see changed, feel free to email any of the people involved, and we'll be happy to honor those requests as best we can. Ajit and I would be happy to hear from you. Please let us know.
David, you want to say a word about the research scholarship?
Sure. So the resident committee for the AHS has worked with the AHSQC to actually put together a resident research grant utilizing the AHSQC. So there's 2 research grants for $2,500 each. And this will actually, residents can submit this and with their idea for what their project is, and then we will review it and we'll give out two of these awards, and they will present their data at the 2017 meeting. And so these will be due June 30th. We'll have on the website a format for how to submit this. But if there's any residents in the room or anybody who works with a resident, this is actually a pretty easy way to get data. And most of it comes to you pretty well analyzed. So if you just come up with an idea, you can get you involved in some research, and also a trip to Cancun in 2017.
So to conclude here, these are the things you can do on Monday. Led to a lot of controversy. They're all listed out here so you can take a picture. Again, I just want to also mention this is not a registry, it's a collaborative. We're making a change. A lot of thanks goes to our patients, number one, first and foremost. That's really why we're here. Shelby Dunstan, who's really kind of the backbone logistically of the AHSQC and what it is. Our surgeons, our FDA colleagues, our AHSQC Foundation, and we anticipate seeing everyone at the college in October. And Mike.
So, one quick announcement before we stop. For those of you who are speaking tomorrow morning, Carol asked me to announce, please upload your presentations tonight, because there was a little bit of a hustle in the morning to do this. And finally, my wrap up for this is congratulations, everybody. I mean, we set out to do something special. I think this is the first real step that we changed everybody's surgical culture. When we think about kind of how far we've come and how long we've done it all as a group and all in a collaborative effort. Based on my presidential address, I think we're going to do great. And I see no reason to not think that we can continue to make improvements, we can continue to measure quality, and we can continue to make hernias great again. Go enjoy the opening session.